and there is a slight change, and we all discuss because all of the panelists happens to be friends. They know each other, so they don't need a moderator. So they have actually recused me from this entire moderation work. So how we are actually going to do is we are going to actually have a conversation between the four people, and let me say that two of them are from the central government or a central autonomous. In one is looking after the IT part or digital transformation from the central government standpoint, and Sushil sir is looking after the infrastructure, the entire core healthcare from the AIIMS side of it, which is the domain and the health ministry. And we have the one of the what you call the leading IT states, which is AP on the right hand side, and the other one is which is now striving towards becoming the number one in India, UP on the left hand side, and became actually number two last year. Yes, it's number two, and it happens that the AP gentleman is also from UP. Okay, so it's a little bit of a everything. Everyone knows everyone. So what I'm going to say is, I'll start with Sunil ji, and up. We will start with the conversation. Please narrate a experience of yours, how you're doing it, probably with the AP only. So you and whatever you're doing, and then Naveen, and we can actually go forward as a thread. And please raise your hand, and in between also we are happy to take questions. We want to keep it interactive. We don't want to actually because it's going to be a short session. So please raise your hand, and if you want to ask a question.
In healthcare, I am into healthcare, especially in IT, since last 10 years, and working with Ministry of Health and Family Welfare. And we primarily work in, say, 5 areas. So one is application software development. I think everybody knows about it. And second is basically we healthcare standards. So, and the third thing is basically latest emerging technologies and their application in healthcare sector. And the fourth one is basically support services, because we are talking about not talking about systems. Now we are talking about ecosystems. So when you say ecosystem, not only healthcare part and the surrounding applications which are taking care of that is also included in. So as far as applications are concerned, we are, as you know, NIC has been into various kind of application. Especially, we have a suite called e-hospital suite, which has a 5 applications. That is HMIS, ORS, that is patient portal. Then again we have e-blood bank, e-collab DDS, and telemedicine solution. So it's a combination of 5 applications, and it is e-hospital suite. And then we have Arogya Setu, which was earlier tracing app. Now it has been being converted into a health app. So it is integrated with ABHA. You can create ABHA ID from, and you can have a connection with the CoWIN. It has integration with the blood bank. So Arogya Setu app, which was earlier tracing app, now being converted into full-fledged health app. And another is basically RCH, reproductive and child health. So this is another application where we have worked a lot of IT into it. So across the country, in all the 36 states and UTs, we are basically monitoring the health of the pregnant women and children. And the last application I think I would like to mention is OxyCare. So in the COVID, all of us knows how oxygen crisis was there, and then we created one portal called OxyCare portal, where we track each and every oxygen device across the country using the same one portal that is called oxycare.gov.in. Oxycare concentrator, oxygen concentrator, PSA plant, and this ventilators and oxygen cylinders. All 4 devices are being monitored through this. So this is about application and standard. I think we are into HR EHR standards and MDDS standard, LGD directory, that is the locational directory. So I think if we look into it, why we are using these standards, ultimate objective is to have integration and interoperability between the health applications. So that is the basic reason. So three things: application, then standards, and then basically interoperability and integration. And the last one is inclusion of basically emerging technologies like AI and blockchain and data analytics. I think we have a lot of efforts are required when we seamlessly integrate all the application at the national level, because states have different solutions. They need to be integrated. They cannot be integrated until unless you have a standards are implemented across all the applications. So this is I just initiated the discussion on these points. So and I think I will come up again where I will describe the various basically key learnings about implementation of these IT system across India.
Thank you, Sunil ji. I think, as he said, all four, I think maybe all the four are invited with me, right? So he is our partner for implementing the software at 54 institutions in AP. We also have an in-house software which is called Dr. Care, which we adopted, and we have put it in around 1600 health facilities. Together, we are the only state with 1667, I'm putting this number, facilities on digital health map. When I say this, I think when we started, I remember we used to sit in Sunilji's room on a Saturday evening, and I think in fact NIC was open on a Sunday also for us to discuss. And then we quickly wanted to see what are the solutions available. And then we rolled out somewhere from October of last year. Right now, you could see the dashboard on the ABDM portal. Andhra Pradesh is the leader in creating digital records. The idea is very simple. All your facilities should be on digital map, which means that your professionals, your nurses, your pharmacists, and all the people who are aligned with it should be on your digital map. The second thing is all your health record. Imagine a boy or a girl is born right now in AP. This record would be available on a digital platform, and 10 years from now, 15 years from now, that is going to be the way forward, right? The reason, I'm also explaining the reason. If you see NCD, non-communicable diseases, that is around 70% of your disease burden. What is NCD? Your cardio diseases, your cancer, the diabetes and hypertension. These diseases need longer care or continuous care. I would put it this way. These are the questions which we are talking, right? So how do you give somebody a continuous care through a public health platform? It will be only through a digital platform, right? So what if that person is not taking medicine? How do you make sure that person is taking medicine? That's where your adherence will come. Any health system, we always talk about 6 A's in the health system. One is awareness, acceptability, accessibility, availability, affordability. The last one, which is called adherence, that's the key. How do you make a system which is, and through digital system it's easy. I would send an alert to my A&M or my ASHA worker telling this is a person who has not taken her treatment or his treatment. What is government? We monitor. So this helps us to monitor better. This is a larger landscape which you are looking at. When we talk about digital record, I think that's when he concluded also. When you talk about digital records, it's not just about putting those records like a paper, right? It's not that what was on paper, you have put it on the system. That is not what we are not looking at digital world. The digital means it's a digitization. If you put that what is on paper, you put it on the digital map, it's just a paper, right? You need to create that the super structure or the super ecosystem over that digital ecosystem, which would mean data analytics, which will also mean monitoring. There are a lot of insights. I'll tell you a very small thing which I did not see when we started doing the record. When we started putting this EHR application in one of our hospitals, government general hospitals, the doctors are telling me, the doctors who are there, they need to do at least 6 or 7 papers to become an associate professor from assistant professor. The doctors were telling me that the need for records, because they were not having records, they were not able to produce research papers. Now, if I have electronic EHR, electronic health record, we could come up with humongous research from the country. I did not even think that this could happen. We started doing it just because there was a idea that we should start digitizing thing. But we could also see there is I don't know it's an unintended consequence or not, but this is the biggest consequence. Remember, all the protocols which we use in India are Western protocols. We do not know how this would be dealing with our population. So that's a larger landscape. When Murty was telling me that should we talk about what we are doing digitizing, we should go beyond digitizing and digitalizing. That's our agenda. We would break, I am very sure which this digital world or digital map or digital health records or a digital health system, we would be the leaders in research. Remember this one. Our country is going to be the leaders in medical research, which we are in the past. And I think this is going to help us. Thank you.
Thank you for inviting me over here to discuss the role of IT in healthcare sector. I am from UP, so people from India looks UP as a leading state because of big state and there are different regions, what I am saying. So one thing I would like to say through example, eSanjeevani is a application, online application, which is providing medical health services to the rural areas. Most of the patients who are using eSanjeevani from the rural areas, and more than 10,000 patients are using in UP. So this is the beauty of the digital health care services from rural areas. There is a sentence, prevention is better than cure. In the first part, as Murty ji said that I should speak on the prevention, but in the second round I will take up the prevention. In the first round I will take up the cure. We are creating all sorts of infrastructure, medical hospitals, doctors, nurses and all that. In spite of all efforts, still many people and many places all over the country is not served. They are unserved. We are not able to provide them the medical health services. So how to make it possible? That is our medical services and education, both are very important for any country. So this Ayushman Bharat digital mission, if implemented in letter and spirit as it is envisaged, as it is planned, it will serve the unserved and unserved places, no doubt about it. Change is always resisted, but in the corona, every crisis is an opportunity. Corona was a crisis, but if you will see from the angle of opportunity, corona had taught us, whether we are living in urban areas or rural areas, that technology is more effective, more efficient, and its impact is far-reaching. So the resistance to adopt technology in the medical sector has gone down drastically. The space required for the technology in health sector is wide and vast now. Second thing, technology is reaching each and every house. How I can say this? In UP, particularly since I am working in UP, so I will quote the example of UP. Every village is having 2 common service centers, and each common service center is a NIC center, as we do have. Every district magistrate have a NIC center. Likewise, we can compare every village headman, every village have 2 NIC centers. So NIC technology facility has reached to each and every village and family and every household. So if we will train them accordingly, they can provide, they can cater the medical services through technology to each and every person who is located in the village and who is yet not served. So that is the beauty. But again, one thing, that is the governance issue. We are very good in paper, in PPT, in doing such seminars and in marketing. But in in implementation on ground, things are different. So we will have to be very cautious. One more thing. Once upon a time, I think 6 months back, I was attending a seminar. In adopting technology, we have to be very cautious. In Indian conditions, we need enabling technology, not replacing technology. If we will take the replacing technology, and other problem will be created, that is the unemployment. So we will have to make a choice in between, so that if we are curing one thing, the another element should not come in picture. So preventive part we will come in the next round. Thank you.
Yeah. Anyway, AIIMS is not a new, means new to you, because everybody know AIIMS means AIIMS New Delhi. Digital transformations in Delhi AIIMS, it has started long back. Before I born, I can tell. Because AIIMS has started computations activities in their research work, because they have used the paper tab as a storage. You since, and right now we have supercomputer at AIIMS premises. So what is the journey you see it? Now I am coming to the real things. AIIMS is not a hospital, first you have to understand. It is a institute for research, training, teaching, promoting high quality of education. Third one is your healthcare. So first two, you have to meet it. You need a hospital environment, otherwise you can't do the research and the teaching and training programs. That's why AIIMS is always looking into the high quality of healthcare services. If you want to have best and good healthcare services, you need to empower the doctors, then they can give a good healthcare. Simple language I am talking about. More data, more healthcare. Less data, less healthcare. If doctors has been empowered with more data of a patient, he can take a more accurate diagnosis and give a treatment to him. If data is not there, he's handicapped. This is the basic simple logic is there. What AIIMS is doing? Since 1988, first computation has been started in the country, that is in AIIMS New Delhi. And the technology helping hand was IIT Delhi and NIC. And that system failed. They have given an extraordinary system, Cyber 930. It was 1.5 crores cost at the time, and this failed because technology is not there what we are expecting. This machine is meant for number crunching, not for the database. We have used Oracle database and it failed. And that is why the Oracle database did not work in the Cyber 930. Then we have started in-house, not it has taken up. But in third try when we have done with association with NIC, and that application is implemented, customized as per our requirements, and it is working perfectly. What we have in the transformation in AIIMS? We have HIS, we have LIS, we have CIS, we have PACS, and we have telehealth. All are seamlessly integrated in single platforms. It is going on. Small example I am giving you. This time, before COVID, we have done a beautiful integrations in the LIS, Laboratory Information System. Laboratory Information System will work in three phases: pre-analytic, analytic, and post-analytic. All are computerized, and the process is seamless process that I will transfer without any manual handling. The sample, just the first process is that collect the sample. Let's take blood. You have to definitely extract the blood from the body. So that is some manual intervention is there. After manual interventions, the blood will go through the pneumatic tubes. It will go to the pre-analytic of the whole systems. From there, the conveyor belt, it will move. The robotic hand pick up the sample, put in the machines where the test has to be performed, that type of test has to be performed. Then that reports, it will be generated. Again, it will be displayed with the doctors. If you have configured in the post analytics, in that cases, in these conditions, it is not required to be visit by the doctor. It will immediately report to the patient's records. So it will transport the patient records. It is totally seamless. Application is NIC. The LIS is, we have Ross and the Siemens. All are totally, you can say one manufacturing unit, what it works. It is like that. And this is the first installation in the country, neither in the private or neither in the government it ever had. So this is 3 years back we have achieved it. And per hour, we are doing, it is about to be 25,000 tests in one setup. We have two setups. One is the Siemens has already installed these things in the NSI Jhajjar. Another one is the in main campus, which is in New Delhi. So this is the digital transformation we have done it. Second thing is that we have tried our level best that the patient journey, how to come down.
I'm looking at the time, so it says 16 and a half minutes. So what I want to do is in next 10 minutes, I want to close it. And then if there is any question, so I'll give the additional 6 minutes to the people so that the previous session thing is compensated here. Sunilji, out of syllabus question. How can you have a wonderful application, even AIIMS is talking about it, I know API has implemented. How can private sector work with you on the application and take this as a product to multiple places? Just not NIC, but can others also take it and start doing it? How can you enable that?
Integration and interoperability. This is the basic requirement. If your application does not support interoperability, make sure your application software will not work. So, what does it mean with respect to your query? So it means if any private sector have any module, they can integrate with us through APIs, and we are open with that. Let me come to the point. All our applications which are recording patient level data, they are integrated with ABDM component. What does that mean? That means it is integrated with the ABA ID. It is integrated with the HFR, that is Health Facility Registry. It is integrated with HPR, that is Health Professional Registry. It is integrated with the PHR app. It means any personal health record can be seen by an individual through his or her mobile. And the last one is it is integrated with consent management. It means the data of one hospital can be shared with the doctor or any health professional through consent of the patient. So these 5 components which have been made available by National Health Authority through a platform, and all our software, all NIC software where patient level data is being recorded, that is being integrated through that. It means we are open system. We can integrate any of the external system, any of the private software if it is implemented. So whenever we go to any hospital, if they say, doctor ka bhi karte, yes, same as, see, in most of the states, they are whatever software, and both of us, they have doctor clinic software, we have e-hospital software, both are working in AP, and both are talking to each other. When I go to one hospital where e-hospital is implemented, and I go to other hospital where doctor clinic software is being implemented, I am able to see my health record on my mobile for both the hospitals. So this is the level of integration we have already realized. So it means we are open to work with the private sector if they want to implement any of the software which are independent, and we can always integrate with e-hospital. So no issue on that.
Thank you. I'll come to you, Heeraji, I'm coming to you first now on the precaution part of it. So you wanted to talk about that very quickly. I'm just trying to see that
Okay. prevention is better than cure. This is a simple and smart sentence. We always focus on the cure, not on the prevention. But time has come that we must give the due importance, due diligence to the prevention. The day before yesterday, I was reading a editorial write-up written by the Harvard professor. He is sitting in Harvard and talking about the prevention in healthcare of India. He told by changing the lifestyles, by providing the infrastructure, by changing food habits and all that, we can prevent the increase in the number of patients, and thereby we will reduce the already overburdened care ecosystems. So how this is possible? With the help of technology. We have machine learning, artificial intelligence, and data analytics. Through that, we can predict in much advance any epidemic, any ailment, and we can prevent that before it occurs. So that is a boon. Adoption of new technology is a boon in the field of the prevention. One thing. I see this in light. Nobody wants to get ill. Nobody wants to get operated. Nobody wants to pay to the hospitals. So, in my opinion, I worship prevention, not the cure. I am worshipper of the prevention. In the last 5 years, I have not taken any tablet because of my food habits, because of my lifestyle, because of my. I am worshipping the prevention. The second thing, cure and prevention are very closely interlinked, but we see them as two identity. If you go to a doctor, they will give two things in the prescription. They will write the tablets and medicines and all that. And then in the second part, they what will they be? You will not eat this, you will not do this, you will not go there, you will not take cold, something like. What is that? That is the prevention. So in the same prescription, whole sentence, prevention and cure, but we are ignoring the prevention. So though both are interconnected, but we are not perceiving that both the things as interconnected and interoperability, as you said. So this technology can connect them, and our perception of separated things can be changed into a close connected things. What I wish to say. Thank you.
Thank you. Thank you. Sushilji, last one. You are going to talk about the patient journey, but I just wanted to add that how can your experience can be a mentor or a kind of a case study for others? Is there something you're also planning to open up your digital transformation journey as an open source case study to others to learn from?
Yeah, as per the, because we follow all the guideline of Government of India. And Government of India recommended that any application has to be developed or used, it is in the open source. So by default, we do not have any option to think of it. You have to go for open source. And e-hospital, what it is for HIMS for, it is open source. Another big components I'm talking about it, many people may not be knowing it, that PACS, Picture, Archival and Communication System. It plays a major role in healthcare services, and that application also it is open source, and this is the only place in the country that open PACS it is developed by third party, but this is owned by AIIMS, and more than 100 modalities connected, and when the image is fetches, it takes 3 to 4 seconds. And if we talk about whole body scanning, it will be around 1,000 images it capture, but that images it will be fetched in the system. At that time, it will hardly take 5 seconds. It will fetch immediately. The network is some network is very old network, still with the performance is very good. So this is the one kind of open source which we have developed from DCM Percy. One application is open sourcely available in the net. We have downloaded it. We have put a third party. We have customized that one as per our requirements, and that browser is there. If we will go for some application from the Siemens or a G or somewhere, each license is very expensive. Why you have choose this one? Because when we have gone for the Siemens, we have asked that you have a PAC system here and we want to have a browser for these places. And we have got a quotation of 20 crores rupees. But when we have gone for this, it is hardly, you can say within 1 crores, everything has been done. So this is the difference of what we have. So when you go for a PACS, be careful because it is very sensitive issues and it is very expensive issues. That's why people do not follow it. So in open source, it is available. You can use it. If your data is limited, let's take, you have data of around 10 TB. It is not require any customizations. Many open source tools are available for the packs. You can use it. If it is more than that, because I have 3 petabyte data, so in that cases, that tools may not be helped. So that's why it's required a customizations, which we have done it. This is the one kind of things we have achieved in only in AIIMS. Nowhere in the country it is there, which has more than 100 modality connected in single platform.
Perfect. That's great. So, I think the last 3 minutes, we want to say 1 minute from there. So 2 minutes. What's next in AP?
See, there are two things which you can achieve using digital system. One is that turnaround time. How can we increase the operational efficiency of the systems, because all the resources are limited. So that is one thing which we should look at. Second is the future of, I call it metaverse, how much we can go. Recently, I could see something called XR, extended reality, right? So what is extended reality? It is virtual reality with your augmented reality. We could see a surgery happening using robotic surgery. The surgeon was telling me, this part of your body, when they do surgery, it's very tricky, right? So they could actually, using a robotic surgery, they could stop there for 2 minutes, drink a coffee and come. That's the beauty. And we are going to have a shortage in medical education. XR is going to change the way, or I would call it the, XR is the pre-beginner of metaverse, the future of healthcare. So metaverse would change the way we look at healthcare. So I think that's the future. So we are looking at maybe 5 years from now, there will be a conference on metaverse. How would metaverse change the healthcare platform? That's it.
So I think the metaverse conference will happen very quickly. So that's for sure. But I think we are closing the session 2 minutes or 1.5 minutes in 10 seconds at least. As a moderator, I should take it. Thanks all the panelists. We have talked about the standards, interoperability of applications. We've talked about the future of the healthcare from the perspective of metaverse or the extended reality. In fact, something which is already happening in India. We have looked at prevention. We looked at how the rural healthcare by e-Sanjeevani project, which is the telemedicine project of Government of India, which is very, very successful. AIIMS has been always a pole bearer in terms of doing the transformation, and we all look forward to that big digital transformation at AIIMS so that we can all learn from that. Thank you, all the panelists. Thank you for bearing with me. We finished before the time. Thank you.